Okay, a little more pharmacology under neurology, part two. We're going to talk about basically what you need to know for anesthesia drugs on step one. It's not a crazy high yield topic, but there's a few things you need to know, so let's go over that real quick. Anesthetic agents. All right, the goal of anesthesia is to produce immobility, amnesia, and or analgesia. Anesthetics now they can be divided into three general classifications. Number one, inhaled anesthetics. Number two, non-volatile anesthetics. And number three, local. Alright, so there's a couple of these under each one of them, so I'm going to list them off there for you. Under your inhaled anesthetics, you're going to have nitrous oxide, isoflurane, desoflurane, sevoflurane, and halothane. So that's nitrous oxide, isoflurane, desoflurane, sevoflurane, a favorite of a lot of hospital anesthesiologists, and halothane. And we're going to go a lot more in depth with these drugs, but for just now, I just want you to understand there's three general classifications. Now, the non-volatile anesthetics include ketamine, propofol, what Michael Jackson's doctor gave him too much of, droperidol, etomidate, benzodiazepines, just gonna write benzos, barbiturates, and opiates. The favorite opiate of a lot of anesthesiologists is fentanyl, which is 50 times more potent than morphine. Now, your local anesthetics are procaine, lidocaine, stuff like that, cocaine. So let's write those in there. Ibogaine, tetracaine, ibogaine, and cocaine. All right, so those are your three general classifications of anesthesia drugs. And moving right along, what are the actions of these CNS anesthetics? They're related to the solubility of the agent in lipids and in blood. So agents with increased lipid solubility are going to have an increased potency. Therefore, they're going to require a lower dose. That's all that's about. Now, agents with a low blood solubility have a fast onset of action and a fast recovery time. So, if I told you that you have an agent with the increased blood solubility, are you going to have a quicker or slow recovery time? You're going to have a slow onset of the drug, and you're going to have a slow recovery of the time if it has an increased blood solubility. This is going to stay in the blood longer, so it's going to take you longer to metabolize it. It's going to take you longer to recover. So that's what that's all about. Now, you need to know in general anesthesia, such as that used in surgery, is divided into three different stages. What are those three different stages? Induction, maintenance, and emergence. Now, agents used for induction include three of them. Propofol, etomidate, and ketamine. Agents used for induction include inhaled gases, and IV general anesthetic drugs. Now, during emergence, there is excessive autonomic responsiveness. So you're going to see a lot of tachycardia. You're going to see a lot of bronchospasm. You're going to see hypertension. So what do we control a lot of this with? Short-acting narcotics, beta blockers, and the favorite, lidocaine. Short-acting narcotics, beta blockers, and lidocaine. Now, there's one big thing here with inhaled gases. There's a lot of theories out there explaining the mechanism of action of these inhaled anesthetics, including the action on cortical centers and inhibition of excitatory transmission in the spinal cord. So what we're going to talk about, I'm going to show you the main inhaled agents, and we're going to talk about the theories and what's going on, including some toxicities. There's a few toxicities you need to know. So the mechanism of action, here's your inhaled anesthetics: nitrous oxide, isoflurane, desflurane, sevoflurane, enflurane, and halothane. Now, the potency of inhaled agents is expressed as the MAC, or the minimal alveolar concentration, MAC. MAC Daddy. The MAC, and that's required to produce anesthesia in 50% of the population. Now, inhaled anesthetics produce the following systemic effects. You want to see cerebral vasodilation. Therefore, increased cerebral blood flow. Therefore, what's that going to lead to? Increased ICP, increased intracranial pressure. You're going to see systemic blood flow or blood pressure decrease. Therefore, you're going to have a decreased systemic vascular resistance. You're going to have a decreased tidal volume. So if I have a decreased tidal volume, what's going to happen to my respiratory rate? It's going to increase. But now, most volatile anesthetics have a depressive effect on the respiratory system. You're going to have a neuromuscular blockade. And also, you're going to have decreased renal blood flow. If you have a decreased renal blood flow, you're going to have a decreased glomerular filtration rate, which is going to lead to a decreased urine output. Now, the toxicities that I was talking about, let's talk about those. The ones we need to talk about: nitrous oxide, halothane, sevoflurane, and enflurane. Nitrous oxide, halothane, sevoflurane, and enflurane. So let's do that. Nitrous oxide, you're going to see an increased pressure or volume of body cavities. And also, vitamin B12 deficiency can occur. Number two, halothane. This is hepatically toxic, so hepatotoxicity. It's called halothane hepatitis, which is exceedingly rare but nevertheless a notable cause of post-operative hepatic dysfunction. Now, I'm going to tell you what, of all the ones they're going to test you on, that's the one I would remember is halothane because I've seen 2 or 3 questions about this on USMLE World, so they really want you to know. I think it's people with a certain dysfunction of the enzyme that they have in their liver, and that's why it's hepatically toxic. They don't have the enzyme that can break this down, so this inhaled anesthetic really causes havoc on their liver post-operatively. Sevoflurane was number 3. That's nephrotoxic. And enflurane, that is a proconvulsant. So those are the 4 toxicities of the inhaled anesthetics that I want you to be aware of. All right, now let's talk about local anesthetics. So local. So local anesthetics. The majority of local anesthetics function by blocking voltage-gated sodium channels. And therefore, you're going to disrupt the impulse of transmission in pain fibers. Now, local anesthetics are used in epidurals, spinal anesthesia, peripheral nerve blocks, and painful skin procedures. They're classified chemically as 2 things, and this is important. Number 1, an ester, or number 2, an amide. There's a very easy way to remember this. And it's all about the I's in the letter. So if it has 1 I, it's an ester. If it has 2 I's, it's an amide. And for example, procaine is spelled Prokine, so therefore it's an ester. Cocaine, Cocaine, that's another ester. Tetracaine, that would be another one. So things that are amides are something like lidocaine, Lidocaine, or bupivacaine, Bupivacaine. So that's just something to look for when you take the USMLE. Right away, if you look at because they're going to give you the name of the drug, or it's going to be in the vignette, you can tell somebody's had an ester or an amide. And remember, these are local anesthetics. Okay, so you automatically know whether they have any cane, you know, is a local anesthetic. And remember, what did I say they're used for? Epidurals, spinal anesthesia, peripheral nerve blocks, and painful skinful procedures. So often given with vasoconstrictors, this increased local concentration while limiting systemic spread. Now the characteristic of nerve fibers contribute to the efficacy of local anesthetics. So the size and the myelination of the fibers is what we're going to have to talk about. Size and myelination. That's what we have to talk about when we're talking about these blockage of voltage-gated calcium channels in nerve fibers. So fibers with a smaller diameter are more easily blocked. It's literally that simple. And now myelinated fibers are more easily blocked than unmyelinated fibers. So if it's myelinated and it's a small nerve, very easy to block that nerve. Now the fibers of different sensory modalities possess different characteristics. There's a loss of sensations in a specific order. This is important, so pay attention to this. Pain is going to be the first thing that's lost. Temperature is going to be the second. touch is going to be the third, and pressure will always be the last thing that is lost. Pain, temperature, touch, pressure. PTTP. That's what you need to know about local anesthetics. So moving right along, let's talk about the toxicity of local anesthetics related to the concentration levels. The most common cause of toxic levels is accidental injection into a blood vessel, which can cause several systemic effects. So in the CNS, you can get tinnitus, disorientation, and seizures. You don't say. Cardiovascularly, you can see hypotension, dysrhythmias, and cardiac arrest. In the GI, we're going to see nausea and vomiting. Pulmonary, you can see respiratory arrest. And immunologically, you can see local allergic reaction and even anaphylaxis. So, lastly, we're going to talk about the non-volatile anesthetics, which is ketamine, propofol, droperidol, and etomidate. We've already talked about them, but let's go more in depth with them. So, these are commonly used non-volatile anesthetics, which include ketamine, propofol, droperidol, etomidate, benzodiazepines, barbiturates, and opiates. Okay, so let's talk about the mechanism of action for each of these. Ketamine is a non-competitive NMDA antagonist. Propofol produces global CNS depression via action on GABA receptors. Droperidol is a surgical antiemetic via anti-dopamine effects. And etomidate is a non-barbiturate hypnotic. All right, so let's talk about some black box warnings here. Ketamine, with a which is a NMDA antagonist, increases cerebral metabolic rate and cerebral blood volume. Thus, it's contraindicated in ICP. So ketamine, contraindicated in cases of increased intracranial pressure. Droperidol has a black box warning, can prolong the QT interval, progressing to torsades points and ventricular fibrillation even. So etomidate has a high incidence of something called myoclonus. 30, 60% chance of myoclonus. And long-term infusions can lead to adrenal cortical suppression. So that is basically all you need to know for anesthesia on step 1. It's not complicated, but you do need to know it. So make sure you review these 7 slides, and you'll be good to go.